Thank you so much for joining us. This podcast is a new edition that is tied to an online course. It's called From the Mentor's Desk. And our main audience are early career or novice researchers trying to build an externally funded research career to do high impact research and save and improve lives. And this is a special series for military medical research, sponsored by the Combat Research Center and part of our Educating Leaders for Innovation and Team Research meeting. And we're so grateful to have you here. And I have as my co-host, Dr. Ian Eisenhower. So we're
Cool.
Grateful to have you.
I'm very excited to be here and grateful for the opportunity.
Thank you so much. Well, Ian and I have been talking to each other about how excited we are to meet you. And we want to know first about your journey, because most often I'm asking people, how did you get into medicine? How did it interface with military life? And then for you, policy work and leadership. Can you, I know in hindsight it all looks like a perfect plan, but do you recall what came first? Was it military or medicine?
Well, there's that old saying that people plan and God laughs. I will say that for people at the beginning of their career thinking, I got to do this, this, and this, just say yes when interesting opportunities come along. That was the secret sauce. I grew up in a military family. My dad, my granddad, my uncle, cousins were all in the Navy. My dad is 98, just turned 98 in January. Still hopes that I'll make something of myself and join the Navy before the end of my career. Married to an ex-Army physician, and we have a son, as we were just talking about, who's a Marine. But the journey really started, according to my mom, at the age of 5, when I was looking at a book on where babies came from. And I said, well, I want to be a doctor because I want to understand this better. And I stuck with that from 5 on and knew I wanted to do it in the military. And when it came time to join, I was too young to join the Navy. They wouldn't give me an age waiver. And so I wound up joining the Air Force because they would give me an age waiver. Again, not what I'd planned, but that's the way it worked out. And
so what age was that?
I was 17.
Okay.
And as different opportunities have come along, I think for many of us, we're told this is the right way to plan your career. You need to do this, then you need to do that. My whole career has been phone call, hey, we've got this really kind of unusual opportunity. Would you? And I've said yes. And I really encourage, especially folks at the beginning of their career, to not get too fixated on here's all the steps that everybody else follows, but instead, what are the things that sound really interesting? Because if anyone had told me that I would work above the Arctic Circle and at the South Pole, in combat and in academia, I would have said there's no way that I was going to get a chance to do all that. But you do something well, and then people say, oh, that's kind of interesting. And then you get the opportunity to do something else that's very different, but again, interesting. I'm incredibly grateful now for 39 years of really challenging jobs in which there was a chance to do what I think was incredibly rewarding work and not at all what I expected. I thought I was going to be an academic surgeon, and then I got a call saying, hey, would you go do a policy job? My very first assignment out of my residency. And I said, I don't want to do that. And they said, well, your other option was something I really didn't want to do. So I said, okay, I'll go do the policy job. That's how these things work out. And then, as I've been in these jobs, have been very fortunate. As I said, my wife is also a physician, and we've been able to make both careers work. Been very clear up front that was always a priority to make both careers work. And she's had to sacrifice more than I had, quite candidly. It's been interesting that as we laid that out for people, that seemed to actually mean something, that there was a commitment to both of our careers and a commitment to trying new things as new opportunities came along. The policy work has been fascinating because, as a surgeon, I still enjoy operating. What's really neat now, though, is when you're in a position where you can actually change the environment in which all of the surgeons or all of the internists are able to do what they do and try and make that a better environment to deliver high-quality health care. The military versus medical part of your question has actually, for me, been very easy because I always bring it back to the privilege of being a doctor taking care of military people. My wife says the same thing as a VA physician now. You know, she loves taking care of vets because she is one, and you know, she spent her whole career doing that. So it's been a lot of looking for those intangible rewards and really interesting, challenging, unexpected opportunities that really led to a phenomenally rewarding 39-year career.
I mean, this is so compelling. And we need to hear about some of these specific opportunities that came your way,
and
right?
I would say one of the things I think is a big hierarchical thing. You've talked many times about the patient first as being a center point. When did that really develop into your mantra or your thought process when you're thinking about, you know, training in urology and those things? When did that really become your kind of center focus?
So it actually was fourth year of medical school, and my inflection point was pediatric oncology or surgery, and I had the opportunity.
Okay, question. Just I need to know more. Why was it one of those two? Because out of all the things you tried, those were your two favorites? You had winnowed that down?
Yes.
Okay.
And
so adult surgery or pediatric oncology?
yes.
Okay.
And again, this
Those are
just
like quite different.
they are, but they, you know, this is being honest with myself, and what I encourage anyone that I mentor to do, really being honest about what it is that you think you're going to love doing. Mm-hmm. And I had a chance to work with a guy named Phil Pizzo, who was running the pediatric part of the National Cancer Institute at the time as a fourth-year medical student. Spent 6 weeks working there, and I discovered about myself, I did not have the emotional resilience to take care of children who were that sick. It was, you know, an incredible experience, still very grateful for it, but it was so clear to me. Every one of those individual kids and their families and their extended, you know, families were impacted by that. And I knew that I wanted to take care of each of those patients, but I also knew that that was going to be really hard for me to do for the next 40 years. Surgery was fun to do. I liked working with my hands. And I really enjoyed the experience. And so I said, well, not this, then that. And then I sat down with one of my mentors, and he said, Paul, it's going to be easy to pick what you want to do based on what you're doing right now. What do you want your life to look like? Do you want to be married? Do you want to know when your kids' birthdays are and actually be there for them? What are your priorities? And I spent a lot of time thinking about that and looking at all the different surgical disciplines. And urology was a nice mix because it has inpatient and outpatient, big and little surgeries, adult and pediatric. And most of the urologists that I work with were actually really happy surgeons. They knew their children's names and when their birthdays were. They had gone on trips with their families and actually made the trip. And so, you know, as I went through that algorithm, I said, this is, I think, where I want to wind up. And I thought academic surgery because I love to learn. I love to create new knowledge and to stimulate people and ask questions and figure out why something is the way it is and how to make it better. And, you know, ironically, I'm finally getting back to that now at the end of my career as an adjunct faculty member at my alma mater. But it's taken me 39 years to get to where I thought I would be at the beginning of my career.
Okay, that is good.
Yeah. The thing that I think is interesting is that one of the first jobs you got after you got the urologist job is not in surgery at all. It was in policy, and you had to step back. Those types of setbacks for physicians can often be really challenging. Do you mind describing a little bit how you felt at the time and also how you dealt with some of those feelings? Because I feel that for many people, those setbacks, whether in research or in their practice, can be really tough.
Yeah, and this goes back to the patient first mantra. Another great mentor of mine, as I was looking at this job, sat me down and said, okay, you know, here's the pros and cons. And I have to give my wife a lot of credit. She's a big believer in the pros and cons approach to life.
Do you draw it on a piece of paper with a line
Oh,
down
we
the
do.
middle?
She's much more diligent about it than I am. But, you know, as we were going through which of these jobs to take, that was one of the points I brought up. I said, you know, I don't want to step back from clinical medicine. And he said, well, then don't. There are those who say it's an either or, and then there are those who say, I'm going to do both. And it's harder, and there's no question about it, and you have to be really honest about that up front. But I continued taking call, I continued operating through the point that I was the command surgeon in the Pacific for the Air Force. And then when I moved to my next senior job after that, stepped back from being a primary surgeon and stepped back from taking call because I was gone so much. But I think that it is in fact, I know it because I've done it. It is possible to do both, and I think it's really valuable. When I was the commander of the DoD VA hospital up in Alaska, I would be sitting there getting the briefs at 9 o'clock in the morning, and they'd say, everything's wonderful, it's unicorns and rainbows. And I'd say, really? Because I was in here at 2 o'clock this morning on call, and the computers weren't working, and we couldn't find supplies. And, there's nothing like actually being there with a patient that needs help and discovering that something that's supposed to work doesn't work. It also, I found, added to my credibility as a clinical leader to be able to say, yeah, I actually am still taking call, I am still operating. To this day, I'm still board certified. I will say that I will be 69 when my board certification expires. I'm not sure that I will renew it at the age of 69. We'll see. That clinical background is, to me, incredibly valuable. I was on the Hill 2 weeks ago talking to the Senate Armed Services Committee testifying, and they were asking a variety of questions. And I, again, said, when you start every answer with what's best for the patient, a lot of the really complex problems become much clearer and much easier to address. If you start with all the bureaucratic buffoonery and all of the, you got to worry about this and that and politics and economics, it's very complex. But if you start with what's the right thing to do for the patient, especially if you've got now decades of working with families and caring for patients, you have a great deal of credibility because you've got a great deal of personal experience. This is what's going to work best for this patient. The patient wants to do it, but the system won't let me. We need to fix that. Or this is what's best for the patient, and they're not sure that they're going to have the support they need to be able to go through that treatment course. We got to fix that. But it's bringing it always back to the patient that builds the most compelling and defensible policies going forward.
That is so fascinating. I just want to reflect. We have a number of, extremely talented physician scientists and leaders here who, have 8 jobs or more, and they really prioritize keeping their, their clinical practice just like enough. They've had enough reps. They're not going to forget how to take care of people. Like our founding director, Dr. Vic Babarda, he's not in the ED all the time, but he's definitely in there. And it is really just such a touchstone for everything, right? Not just like the idea of it, but the patient I saw last week or whatever.
Yeah, and I'll be honest, especially in the last 2 years, I have stepped back from clinical practice because of the schedule and the responsibilities that I had. But that was after many decades of clinical care going forward. And I think for the young researchers and for the young physicians who are grappling with it, many times I hear this binary construct that either I'm going to do this or I'm going to do that. When in reality, at least in my case, I've had a new career almost every 2 years. But the constant in all of that was still patient care, up until just a few years ago. And I think that that's a good way to look at it, that rather than a binary choice, that I'm either going to do this or I'm going to do that, it's how do I do all of it? And are there, if you're a family person, you have to have great support at home to be able to do that. And then you have to have a clearer understanding of, yes, I am choosing, in my case, a lot of things that I could have done that personally I enjoyed doing, I chose not to do in order to do some of these other things, like still seeing patients and being in a leadership role and doing research or whatever the combination may be for the individual. And I think, you brought up the center here, and you've had some interesting experiences here at Colorado. What's remarkable here in Colorado, and we were just talking about this earlier today, is there's not a fixation on we're either doing clinical care or we're doing research. We're doing it all. I mean, this center is, I think, one of the real benchmarks around the country because it's a combination of clinical researchers, what I call pure researchers, the true scientists who, are PhDs and experts in their background, and epidemiologists and people who are experts in communication in an ecosystem that is one of the best public-private partnerships that exist in the United States today. And there's really two places that have done this exceptionally well. One's here in Colorado, another one's in Omaha. We've got a similar ecosystem in New York and a few other places. But it's how do we bring everybody that shares a commitment to high-quality patient care, shares a commitment to research, shares a commitment to innovation, bring all of those people together so that we're working as a team towards that vision of always better tomorrow than we were today. That's pretty unique, and I think that's one of the really remarkable things about this center.
Oh, well, thank you. I will add, I think that's part of what's so wonderful about academic medicine, frankly, because I always felt, I'm a non-clinical PhD. I mean, I can do anything, as long as I can get support for it. And, how free is that? And it allows, it's a system that will encourages you to innovate. It's, even though people think of this as a hierarchical system, it's actually highly, highly collaborative. And a couple of years ago, I had a chance to be on a board, a nonprofit board, as a favor for a neighbor, and I thought, well, that's very interesting. I'm old enough to do that now. I should see what that's all about. And I sat on the board of a nonprofit, and I couldn't believe what I was seeing. I never would have dreamed that I would say, I'm in the house of medicine, and it is so collaborative, and it's so empowering. And compared to this nonprofit business group, they were like, no, it's this way, it's this way, it's this way. And frankly, they ultimately failed. They went out of business in front of my eyes. And I thought, poor leadership. And the culture, the way of doing things was just going to drive to the lowest common denominator. In contrast, in this school, at this university, in the center, everyone is just so open to trying things. It's like the norm. They want you to do something new. If you think you're done, you're in the wrong place because you're never done, right? It's very interesting to think about the ethos of the group you're with and whether it feels like you've found your people or not.
Some might say the military is a fairly hierarchical place. Not everybody, but I think most people would say that. And people will often say, how in the hell did you get promoted? You just don't follow the rules very well. And it's a fair question to ask. Part of it is that as you work in those very hierarchical environments, you seek out the leaders who will empower you to say, well, why are we doing this? This doesn't actually make sense. And I was really fortunate early in my career, the very first year that I was out of my residency, I had a patient who came in, and I examined him and gave him some advice, and we had a little bit of time left over, and we were chatting, and he looked at me and he says, you don't seem quite as arrogant as most doctors. And I'm like, well, you don't seem quite as arrogant as most generals, which I don't think was the answer he was expecting. But we wound up hitting it off, and he became like a second father and an incredible mentor to me. He was a Naval Academy class of '54 graduate who wound up joining the Air Force, and because there was no Air Force Academy back then, retired as a 3-star, and then went on to work as a senior executive in the DoD. So he had nearly 60 years of government service. Tremendous servant leader. So the first time I was selected for a command, he took me out to lunch, and he said, okay, so Paul, you're going to be a commander. What's the most important thing you need to know? And I gave him some politically correct answer. And he's like, well, that was very politically correct, but that's wrong. And so I tried again, and I whiffed again. And he's like, well, you're a doctor. Doctors don't really know a lot about leadership here, so, this is a fighter pilot, smile on his face. It's like, it's very easy. the most important thing you need to do as a leader is create an environment in which everybody else on the team has the opportunity to excel. It says they won't all excel, but your job is to make sure every one of them has the opportunity to excel. And the greatest successes that I've had over the last 39 years are where we've had environments like that, where the leadership team believed their job was to get the barriers out of the way, to create that environment where if someone wanted to knock it out of the park, they had the resources to do it, they had the top cover to do it, and if they actually struck out, it was okay because they knew that the leadership team had their back. The most miserable experiences in my life were where you had no sense that your leadership team was supporting you, you had no sense that you were going to have the resources that you need, you didn't know what tomorrow was going to bring because there was poor communication. And I think this has, for me, been a great touchstone to keep coming back to. They don't need me to be another really good urologist at this stage of my life. There are a lot of good urologists out there. But what we will always need are clinical leaders who understand that as they move higher and higher in the hierarchies that exist in every organization, their real job is get rid of the silos, flatten the organization, and make it as easy as possible for those people who want to excel to be able to do that, to innovate or to deliver patient care in a new way, to try new things and see if they work, to do research. And I think this is the real opportunity for young researchers and young medical leaders today. It's easy to look at what's happening right now and say, oh my gosh, this is so distressing and frustrating and I don't know what's happening. What I keep coming back to, and this goes back to the patient first, there is no universe in which there are not going to be sick people around for the foreseeable future. And there's no universe in which they're not going to need good doctors and nurses and pharmacists to take care of them. There's no universe in which we should not continue to look for better ways to take care of our patients. And if you accept those three truths, then there's always going to be opportunities. And yes, there'll be some turbulence and there'll be times when you look at what's happening and say, I don't quite know how this is going to turn out. But we actually do. We know that tomorrow there's still going to be patients showing up in the emergency room, there's still going to be patients showing up in our clinics, and a year from now, and 10 years from now. And if we keep that as our touchstone, then it can help us when people ask us, is what's happening right now making it easier or harder for you to take care of the patients, to give an honest, defensible answer, and walk in the door of the next patient and know that you're going to take care of somebody who needs your help.
That's amazing. And it reflects upon the cultural building that needs to occur in a lot of these commands. And I wonder how often you felt like you walked into a culture that really matched what your culture you wanted it to be and how you built it into the culture you wanted it to be. Because I think whether it's a military leader or a research leader, I think creating a culture that's successful and gives people that space is really hard. And it's hard often for people to trust leaders, especially if they were not necessarily able to trust the last leader. And so I wonder how you really built that culture for people to help them excel.
And can I build on that before you answer it? Try to think of your earlier career self, because I do think it is different when you're more established and you can afford to sort of go in there and say, but some of the, can you be the change if you're a young, lower ranking person?
I believe you can. I mean, the first 4 jobs that I had, I was the youngest person in that role. I was, told I was too junior for it. First, you have to, have that belief that whoever hired you to be in that role actually believed that you could do it. But, I made most of the mistakes in the leadership books that are out there at one point in time or another. And I think the most successful leaders are the ones who learn from those mistakes. My very first leadership opportunity, I walked in and said, well, we need to change this, we're going to do that, I've got a vision, and everybody was like, huh. And I learned from that because, they want to know that you understand the business and whatever else, but they kind of want to be part of the change. They want to be part of the discussion. They want to feel like they're valued and that they have some input in the environment in which they're going to be working with you as the leader. And I thought, next time maybe I'll listen before I talk. And that turned out to be a great tool to leverage. My wife says I should still work on my listening skills, but I think that those are the sorts of things that come with having multiple opportunities, whether it's as the chief of a clinic or the chief of a department, or the head of a hospital or of a regional healthcare system, or like in my last job working in the White House, someone told me, they said, you spend too much time letting other people tell you what you should do. I said, no, I don't think I spend enough, because I want everyone at the end of the day, when we make a decision, to know they were heard and to see at least something that they contributed was part of the final plan. Because if they look at the final plan that we come up with and they're like, I don't see anything in there that I suggested, obviously they didn't listen to me, I wasn't valued, they're not going to buy into it. They're not going to feel like they're part of it. But if everybody around the table can say, well, I see 2 of the things that I talked about, I don't see the other 3 in there, but I know at least I was heard and I was valued, you're much more likely to get buy-in and support to move forward. And people need to see that you're willing to make mistakes, try something, and if it doesn't work, try something else and go forward. The most rewarding parts are where you can go and say, okay, this was a spectacular failure. This absolutely did. I'm thinking back to one job that I had where we said we were going to do weekend clinics because we were having access problems. And it turns out moms didn't want to bring their kids to the clinic on Saturday morning, shockingly enough. So, the staff weren't excited to be there, and it turns out the moms weren't excited to be there. So it looked like a great idea on paper, but it didn't work in our community. And we tried it for about 6 months, and and finally we said, great idea, didn't work for squat. Let's try something else. And everybody was really good with that because they saw that we were a learning organization, that we could actually step back from a decision and admit, yeah, this actually didn't work. And then you move on. That's in my mind actually the fun part of it, because then people start saying, well, let's try this next. Let's try something else and see what happens. There's a guy named Dave Baker who just won the Nobel Prize up at University of Washington. And he's created a remarkable team that's doing some of the most cutting-edge research in genomics and the marriage of AI and biotechnology. And what's amazing, every time I talk to him or to his team, is their question is, so what are we going to do tomorrow? It's always, how do we keep pushing forward? How do we generate new knowledge? What's the next cool thing to tackle? That's what you want to create, is that environment which people come in and say, even if it's just doing urology. What are we going to do better tomorrow than we did yesterday? That's when it gets to be really fun.
That's incredible. This is great wisdom. I also can hardly believe we only have time for one more question. So here's what I want it to be. Because Ian has told me some amazing stories about how he made himself known to people thinking forward who could help him get into the academy or whatever. And I'm curious, I know lots of, early career novice researchers thinking, I'm not a positional leader yet. How do I prepare myself or become known as a potential to innovative leaders like you?
So I think one of the most important attributes of a rising leader is that they're known for being incredibly truthful, that they've got that reputation for integrity and for honesty. I had plenty of people who thought that, their job was to tell me that everything was going well. And instead, what I really look for, and my best bosses look for, was tell me the truth. If something's not working, tell me early. Don't tell me late in the process that we have a big problem there. So I think being truthful is really important, and not everyone will embrace that. But the good leaders will say, here's someone who will tell me what I need to hear, not what I want to hear. And then the second thing is you got to be truthful, but you also have to be tactful. There's a way to say this sucks that can frustrate everybody in the room and make them think you're just a whiner. And there's a way to say it that makes them think you really care. And if you start with, we had 50 patients last month who could not get in to the emergency room in under 6 hours. There's got to be a way to cut that waiting time down. That's very different than, man, waiting time sucks. And if you frame it from the standpoint of the patient experience, most people will buy into that and will say, yeah, I want to be part of figuring out a solution to that. And then as a young leader, bringing solutions to the table, because you got to be truthful about the problem, you got to actually describe the problem the right way, but then have something to offer. I I remember one group of docs who worked for me who came to me and said, "You're working us too hard. This is terrible. You need to cut our hours back. We're seeing too many patients." And I said, "Great. So what do we do with the patients that you're not going to see?" And it was just stunned silence. And I'm like, okay, so we can't have a conversation about how we're going to change if it starts and stops with, "I don't want to work so hard for patients," because that's not the yardstick that I care about. It's got to start with the patients. If you're not going to see them, who is going to see them? What's plan B? And when you can come to the table as someone with a reputation for truthfulness, who frames a problem from the patient context and can offer, here's 3 things that may work. I recommend we start with this one. Let's try it for 6 weeks. And if this doesn't work, then here's plan B. Then people are like, that's great. Let's do it. Let's try it. And, and come back in 6 weeks, give me an update on where we are. I think, if you can take that approach as a young leader, then people will say, what was that guy's name, the really annoying urologist? The guy who's always coming up with, yeah, get him back in here because we need him to help us solve this problem. That's how it works. You build that reputation for truthfulness, for patient-centeredness, and for actually coming up with solutions, not just describing the problem. And over time, they're like, what was his name again? I can't talk to him for too long because it makes my head hurt. But I want him back in here because we need his help to figure this out, or we need her help to figure this out. And then the last thing that I'll say for young folks is have your support system around you. I'm incredibly fortunate. This year we'll celebrate our 30th anniversary. My parents just celebrated their 62nd anniversary. Having people around you who will put up with the good days and the bad days, and who will say when you come home, don't talk to me, this was a terrible day, or let's celebrate something, that really helps to have that support system. Because at the end of the day, as I've walked away now from 39 years of government service, I walked away with my family intact, and I'm really grateful for their support over the years. But that started at the beginning of the career, and it enabled the entire career going forward. The most rewarding thing is when you see 2 stories. One, first weekend in one of our deployments, we had an attack on our housing area. We had a young man who lost both legs and an arm, and very long, complicated clinical course. Operated on him for a long time, 36 units of blood. And then 9 months later, to see him skiing at the Paralympics facility, these are the extraordinary things, the privilege that we have as doctors and as researchers to come up with things that allow us to take someone who should never have survived, in no other conflict would he have survived, and have him skiing at the Paralympics facility 9 months later. That's the privilege of what we get to do. And then the pleasure side of mentoring. So, I was just texting with someone who I met as a very young physician, and she's just retiring at the end of her career and going on to the next chapter. And to have seen her grow to become a leader, to follow in some of the jobs that I had, and to see her actually doing better than I did, it's like, okay, what an incredible pleasure to see the next generation taking what we did, make it better, and then turn it over to the generation behind them. That gives me great hope that in spite of all the turmoil that may be happening today, there's still a heck of a lot of really dedicated people out there who put patients first, who recognize what a privilege it is to take care of them, and what a pleasure it is to work with great colleagues.
Thank you so much.
Thank you. I look forward to the chance to do this again.
Yes, to be continued.
Yes,
Okay.
absolutely.
Thank you.